Today, inshallah, we're going to talk about the MIS options for treating metastatic spine disease. First of all, I would like to thank the organizing committee, Dr. Faisal, Dr. Abdul Karim, for their generous invitation and great organization. So when we talk about patient with metastatic spine problems, we have to consider a lot of things: patient morbidity, life expectancy, stabilization, and all these things should be considered in treating these patients. We have many options. So I'm going to start with one of my cases. This is a sweet 70 years old lady who has breast cancer with multiple mets. She was going well after her mastectomy and going through hormonal therapy, and she developed this pathological fracture in T11. She was doing well until she developed this fracture. She was having severe pain, disabled, and not able to do her, usual activity. So after assessing her pathological fracture, we decided to, as you can see, there is not much of involvement in the pedicles. Posterior column or posterior wall is intact. There's a collapse, but not much of a kyphosis. No cord compression, only the instability. So we've decided to do just the minimal for this old lady with one screw above, one below, minimal invasive, quick procedure, 45 minutes. Patient did well post-operatively. Her pain improved dramatically. She was able to mobilize. A month later, she came to ER in severe sepsis with this huge prevertebral abscess, and we were able to manage her with drainage of this abscess and IV antibiotic, and she eventually recovered. I'm presenting this to say how these patients are very vulnerable, and we need to be very cautious in treating them and trying to give them the best outcome with the less complication. Most of them, they don't have much of time, and they need to go or become more functional and go back to their, at least, a decent lifestyle. And this after her recovery. So as we all know, the spine is the most common osseous site for mets. Usually it is coming from breast, lungs, prostate, and kidneys as it goes. It's symptomatic mets in around 10% of all cancer patients. Stability and neurological status, comorbidity, life expectancy, all these things should be considered when treating these patients. Treatment strategy is most likely palliative, except for a few cases with a single mets, as the one presented by Dr. Barnawi. But most of them, their treatment is palliative, so we want to give the patient the best quality of life for their remaining time. MIS techniques have potential to decrease surgical morbidity, time, blood loss, and return to early systematic radiation and chemotherapy. The options available is kyphoplasty, vertebroplasty, percutaneous fixation, fenestrated screws, tubular retractors, mini open, and thoracoscopy and endoscopy. Integration of stereotactic radiosurgery, which I think we should be concentrating on that and giving some session talking about the update of this concentrated radiotherapy. As we all know, giving patient around the spine or the spinal cord big doses of radiation might not be the best option with significant complications. So these type of strategies could be very helpful. So when assessing patients with spinal mets, we have to do our own assessments. Some oncologists are optimistic, or others are pessimistic, so we use our own scoring. I think surgeons should make their own decision. So we use Takahashi for the survival, and it helps in the decision making of which type of surgeries, and also we use the sense for stability. I will go through some of the literature comparing or talking about the different strategies of minimally invasive options. So this is a nice review comparing or evaluating the outcomes of minimally invasive approaches in spine mets. They concluded a very nice algorithm at the end of the study. They did a literature review. They reviewed more than 50 articles, and they came up with this algorithm. So it gives you an idea how to approach these patients. So patient without a neurological deficit, even if there is a compression radiologically, they would advise to, determining this tumor, is it radiosensitive, is it chemosensitive or not? It will also give you a hint in decision making. They've noticed in the previous literature review that most patients with minimal invasive approaches have a very long segment of fixation, 2 or 3 levels above and below, and this will add more morbidity for patients with their condition. So they came up with a very nice technique, which I use it widely in our practice, which is short segment percutaneous fixation with cement augmentation above and below, with kyphoplasty at the fracture site. So this is usually what the final picture. It has some indications. So even if you need some decompression from the posterior element, that can be done in a percutaneous way. Very nice results. I didn't find much of studies on this technique. We are doing our own case series, but the results are promising. A quick technique, failure rate is limited to less than 10%. And the pain improvement is significant, and it also helps to hold the osteoporotic and infiltrated vertebrae above and below the fracture. Another review, or actually a cohort study, they compared open versus MIS techniques. They have, but I think most of these studies are, we cannot rely on them, logistically, because some patients with the, when we decide to do open for a patient, maybe the MIS techniques will not be appropriate due to multiple factors, including complete collapse of the vertebra that you need to do corpectomy and restoration of the anterior column. So you cannot do this in a minimally invasive way. Some authors are talking about this, a mini open, yes, but the usual standard of care is to do an open corpectomy with visualization of the cord and reconstruction of the anterior column. So in general, most of the studies would say that blood loss, time, hospital stay, everything is less with minimally invasive. But again, I think minimally invasive, we should be careful to achieve the goals of surgery. If you can do it minimally invasive, this is the indication. So this is what they reviewed. Another study mentioned our comparison between the posterior thoracotomy, corpectomy in the thoracic spine, comparing open and mini open technique. Again, same results. Mini open has less blood loss, less time in OR, less hospital stay, but more of X-ray or fluoroscopy use. Another study also confirms the same results with the same conclusion. This is a very nice review. They also concluded an algorithm to how to approach patient with MITS and using the minimally invasive techniques. So it can go from posterior stabilization to kyphoplasty. I mean, using a decompression with mini open technique. If you don't need only the fracture without I mean destabilization from the tumor, you can go only for kyphoplasty. To conclude, we have to know that spine METs is a very common pathology. As we mentioned, 10% of patients with cancer and of all cancers have asymptomatic spine METs, differing from just mechanical pain to severe neurological compromise with cord compression. A long time ago, with so many studies, surgery has been proven to be superior than giving only radiation or chemotherapy. Not to forget that many patients or some tumors are radioresistant. Combining these two with stereotactic radiotherapy and surgery, I think this is the future of spine METs treatment. When we compare MIS intervention with comparable result with open surgery with less morbidities, but again, we have to be careful or make sure that MIS technique will achieve the goals or our goals of surgery. Using the technique, as I mentioned, I think it's very promising to do the augmented screws above and below with vertebroplasty in the middle or in the fracture site. I think this is a very, very nice technique with a very excellent results and should be adopted rather than going through a long segment fixation. Thank you very much.